Dr. Kugelmass will join us momentarily. We just had a function honoring his time here at Baystate Health. I want to just share a little bit about Dr. Kugelmass. So this morning you're going to hear from Dr. Kugelmass. He's been here at Baystate for the last 9 years, leading our heart and vascular program. He'll be leaving toward the end of the year to become the Executive Vice President and Chief Medical Officer of the Deborah Heart and Lung in New Jersey. And a couple of highlights from Dr. Kugelmass's career. He has co-led the team that has designed and opened the Hospital of the Future, which catalyzed the formation of an integrated heart and vascular service line that has grown Baystate Medical Center and brought excellence in clinical outcomes to the communities we serve. His leadership, he has expanded the scope of the cardiovascular services at Baystate Health to include many different therapies and procedures, and nurtured an important relationship with Berkshire Health and cardiovascular services. Most importantly, he has recruited top-notch cardiovascular provider talent to Baystate Health, including an NIH-funded research program. And his leadership has resulted in a skilled and committed team of professionals who deliver state-of-the-art, high-quality cardiovascular care to communities across Western Massachusetts, Northern Connecticut, Southern Vermont, and New Hampshire. And most importantly for Ari, a lot of us know Ari. He is just an absolute wonderful person, incredible colleague. I arrived here 5 years ago, and he welcomed me with open arms as the leader of the Baystate Health Foundation. And there's no greater friend of Baystate Health than Ari Kugelmass. Dr. Kugelmass, how are you?
I'm good. Just having technical challenges at multiple levels.
That's okay.
Apologies.
That's okay. Hey, I just did your introduction. I gave a little bit of highlights from your time here at Baystate Health, and I most importantly just share with everybody how much you mean to all of us as a friend and a colleague, and how much we're going to miss you. So, without further ado, I'm going to turn the program over to Dr. Kugelmass for an update, and I'll be back with some questions later in the program.
All right, thanks, Scott. Hi, everybody. Sorry I'm a few minutes late. Couldn't be a departure without some sort of technical Zoom challenge, but you know, to Scott's point, I think it's well known, I'll be leaving December 1st, but I did want to give everybody an update prior to my departure. Kate, do you have the slides? Can you pull those up? And I'm just going to ask you to advance them. So if you go forward to the, so, you know, part of what I was asked to do, and I really want to do, is sort of bring you up to speed as to what's new in H&V at this point in time. We've done these before, and there's a lot going on. I think probably the biggest thing going on is all of the operating rooms at Baystate Medical Center are being coalesced around what used to be the Heart and Vascular Operating Room Suite. And there'll be a total of 24 operating rooms between what was H&V and the Daly building. And adjacent to that are new labs, for lack of a better word, electrophysiology labs, cardiac cath labs, places where we're going to do structural heart like TAVR, and something that's really new, which is dedicated neurointerventional labs. The neurointervention has been a huge breakthrough. I'm not really here to speak to neurosciences, but I will. The treatment of stroke is just made leaps and bounds, sort of as the treatment of acute heart attack did as well. And it, again, uses the same sort of technologies that are basically cath lab based. And, you know, they require their own dedicated labs. We've been sharing them for a while, and that's worked out well, but I think this is going to work out much better for the neurointerventional program and the acute group. So this is really going to bring everybody together, which was really the plan all along for H&V, and it'll be good to have the other surgeons in the area for very complex cases that sort of need to go back and forth. Other things that continue to advance are patient care. Needless to say, we are very, very, very busy. We continue to move forward with new techniques and new technologies. Our growth strategies for heart and vascular are really focused on that. They're focused on advances in the treatment of valvular heart disease, mitral valves, aortic valves, tricuspid valves. Much as we've seen with TAVR, you're going to start seeing the same with mitral valves and tricuspid valves already. The heart attack program or MI program remains very robust. We're looking to expand in the area of what's called aortic disease, the disease of the largest blood vessel in the body. We've recruited a new doctor, Hazel Marecki, who comes to us from UMass. She's got these very advanced techniques, and those techniques will start being put to use in these new rooms when they open in March. And then there's research and education, and that's a huge thing. And I want to sort of reiterate the role that the foundation has had in helping support both research and education. When I came here 13 or 14 years ago, one of my tasks was to create a research program. And after much consultation with various people around the country, we decided that we would focus on what's called outcomes research rather than lab bench research or just what drug works better than the other drug, sort of looking at what's now called implementation science, understanding where quality is, where opportunities go. And to that end, we were able to recruit someone who showed promise very early on. And with the support of the foundation, we've been able to fund this gentleman to sort of launch his research career. Training grants pay for but a fraction of what it costs to bring a researcher in. But I'm happy to say that after that level of support, this individual, as a member of the cardiology faculty, has not gotten one major NIH grant, but two major NIH grants, overall worth more than $6 or $7 million in his first go round, which is really, it's just unheard of. It's such a success. So this keeps him here to stay. It keeps Baystate on the map. It expands other people's research opportunities. This has been linked very tightly to Peter Lindenauer, who works in the new Department of Population Science, Population Health and Implementation Science. But this has been a huge kudo for Heart and Vascular and for Baystate, and I'll be quite transparent. I don't think it would have happened without foundation support, which really means your support. And so thank you for that. Next slide. Okay. Thanks. So these are just some pictures of what's being built down underneath the healing garden where we just were. To the upper left-hand corner is one of the sort of pre-op, post-op recovery bays that will be used. You can sort of see what that whole area looks like in the next slide to the right, the one subsequent to that. And again, way over on the right. On the bottom left-hand corner, you see a brand new operating room. These are huge, and I'll get into some of the details of that. The next thing you see looks to me like a single plane cath lab with boxes put on the cath lab table. May none of us ever need to be on that table, but if we do, this is the place to do it. And the pictures beyond that are what are called biplane labs, where you can actually look at whatever it is you're trying to study from two different angles. And those are very useful in electrophysiology, they're useful in structural heart disease, and they're absolutely essential in these neuroendovascular suites that we've been talking about for the stroke program. What I will say is these rooms are very, very large, and they are all basically built the same. A lot of thought went into this endeavor with the idea that we will be doing things 10 years from now and 15 years from now and 20 years from now that we don't even comprehend at this point in time. And so we wanted rooms that could be built out interchangeably. At some point, we may not be doing cardiac catheterization. Well, that room will be purposed for something else that we are doing, whether it's in heart and vascular or general surgery or neurosurgery or orthopedics. So a lot of thought went into this. They're all interchangeable. And they're all modifiable and have been built that way. So this has been a huge endeavor from a capital perspective. I'll let I'll let Scott talk about that a little bit more when I'm done. But I just want to give you a sense of what these things are looking like. And it is really impressive. I was down there yesterday. It's really come along. They should start opening up in the next few months, and it will really advance care, not just in heart and vascular, but across Baystate. Next slide, Kate. So I sort of wanted to sort of reflect on some of the things that have gone on since I got here. As we were out on the healing garden, you know, so Betty LaRue and I sort of reminisce that when I got here 14 years ago, that was either a parking lot or the remnants of the nurses' housing quarters. And if you look around, it was just a huge undertaking to build the hospital of the future, which is now also becoming the hospital of the present, beyond just heart and vascular. And so I'm really quite indebted to Baystate to have been invited to come in and build that heart and vascular center, and then in turn build the heart and vascular program. That was a huge multidisciplinary endeavor that really encompassed providers, nurses, other clinical specialties, but also administration, philanthropy, finance, quality, and many others who I'm sure I am leaving out at this point in time. But it was that level of collaboration that Baystate, I think, is known for, that allowed the Heart and Vascular Center and then the Heart and Vascular Program to really become what it is. And when you start getting administrators and clinicians, and providers, finance people working together, it's really impressive to how much you can accomplish over what was once a parking lot not all that long ago. So as I thought back of many people I've encountered over the years as patients, one came to mind in part because I saw her recently. She's currently an 84-year-old woman. I was caring for her son, who had numerous cardiovascular problems, probably going back to about 2010, 2012, when he came into my office one day for his visit and told me about his mom. This is in 2014, his mom, who was, not in good shape over the HVCC and the Heart and Vascular Center. And so he told me what went on. And in a nutshell, she had suffered a heart attack. She was what we call in cardiogenic shock. Her heart was unable to pump adequate blood to her body. And beyond that, she, in fact, because of the heart attack, had perforated the left ventricle, or basically torn her heart open, and was at risk of having blood surround it and expiring. This, as I told the son, hopefully kind and compassionate words, was basically almost always fatal. Well, because of what we've been able to do, Dr. Deaton, many of whom you know, one way or another, operated on her. She defied the odds. She survived. She actually had restoration of her heart function. And now 8 years later, and this was about 2 weeks ago, she has no cardiac complaints. And her biggest complaint is that her knee arthritis is driving her crazy and doesn't allow her to do what she wants to do at the age of 84. And she was giving piano lessons prior to her MI, and she's giving piano lessons to this day. So this is really what all this represents. It's about programs, it's about facilities, but at the end of the day, it's the impact we make on individual patients and their families. And I really want to thank everybody for their support in doing that. Next slide. And it's supportive of the Heart and Vascular Program. It's been supportive of this entire team. And I personally want to thank you for your support of me in this role. It's meant a lot to me. I've developed really meaningful relationships with many of you, and I'll take those with me when I move to New Jersey and embark on my next adventure. So with that, I'm going to get quiet and let Scott say some words and open things up for questions, because this is really an opportunity for you to ask me things more than for me to speak into a screen.
Thank you, Dr. Kugelmass, as always. Hey, we do have some questions that were sent in previously, and the chat function is enabled. So if anybody has any further questions, please feel welcome to send those along, and we'll get through as many as we can. Some questions here, Dr. Kugelmass. What kind of effects have you seen in your patients from long COVID?
I mean, happily, I haven't seen that many patients with long COVID, but it's out there. And I think that, everybody's affected differently. I just recently saw somebody who was having a lot of shortness of breath and had not seen a lung doctor yet, but had had COVID. And when we sat down and talked about things, all this shortness of breath and fatigue and inability to do anything, as well as a lot of mind cloudiness, all sort of dated back to their first episode of COVID, which, if I recall, was sort of in the autumn of 2020. This was an individual who was, he wasn't a physician, he was a chiropractor, and the cloudiness really and the shortness of breath impaired him to the point that he could not continue to practice. So it's definitely out there. There are neurologic sequelae. There are pulmonary sequelae. On the cardiac side, we were very, very, very worried about the acute impact of COVID in terms of increase in heart attacks. What's also been known, it's called myocarditis or congestive heart failure, and then arrhythmias. I haven't seen so much of that with long COVID, but we have seen some of it. And at one point, we had opened up a long COVID cardiac group inside the long COVID clinic. So you don't hear as much about long COVID anymore as perhaps we did early on. It looks like some people or many people get past it, but it's still out there, and it can have significant effects both on the heart, on the lungs, and many other organ systems.
Possibly a question to follow up on that one. Have we learned anything more about how COVID impacts cardio health?
Well, we know it induces what's called a hypercoagulable state or an increased risk of blood clotting. That is for certain. And there were increases in heart attacks associated with COVID. We know it predisposes to certain arrhythmias. Much of that's atrial fibrillation, but there are other ventricular arrhythmias. As I said, it can cause myocarditis or decreased squeezing function of the heart. That may be temporary or may be permanent. There was also concern that some of the vaccines may have had that impact in young males in particular. And then last but not least, and I think this is a big one, it's associated with something called postural orthostatic tachycardia syndrome, or POTS for short. This is something that existed before. It probably is the result, not on the heart, but rather on the part of the inflammation and infection of the part of the nervous system, the central nervous system, that helps control heart rate and blood pressure. So its direct effect is probably more neurologic than anything else, but the sequelae or the physiologic consequences are in fact very cardiac in nature. People are lightheaded, they can pass out, their heart races, and there are certain things we can do for this, mostly having to do with physical therapy and exercise. But it was seen before COVID. It was thought to potentially be associated with other viruses, but a lot of POTS following COVID infections, particularly the first wave, the beginning of the pandemic. These newer variants that seem to be more contagious, but perhaps less lethal. We're not seeing as much of that, but it's still a possibility. So a lot of different sequelae.
Thank you. Just got a question in the chat. Can you expand on advances in aortic surgery?
Sure. So we've already had some of these advances. The aorta is a very large vessel that goes from the heart basically down into your legs, or down into your abdomen, where it then splits into the iliac arteries and then supplies your groin and your legs. It also supplies all the blood to the branches that go to your brain, to your spinal cord, to your entire digestive system and the like, but we're not here to do anatomy. The aorta is prone to different types of diseases. Some of it can be atherosclerotic, aneurysms and stenoses. And we tend to break aortic disease down into the diseases of the aorta that occur within the chest, and then the diseases that occur below the chest or below the diaphragm into the abdomen and elsewhere. And classically, the cardiac surgeons worked above the diaphragm and the vascular surgeons worked below the diaphragm. You can develop aneurysms. Some of this can be associated with certain connective tissue diseases. It's associated with things like Marfan syndrome. People who are really tall. Abraham Lincoln was thought to have Marfan syndrome. And that's a connective tissue problem, and patients are prone to dissection or rupture of the thoracic aorta. But some patients are prone to aneurysms in the abdomen. And classically, these were treated with operations, and the operations were huge deals. Very high mortality rates, very high morbidity or complication rates, people in the hospital for a long, long time. About the time I came out of training, they started using stents, covered stents, to treat the aneurysms in the lower aorta. And those have gotten sophisticated. But they're challenging when you're trying to get across another place where another branch blood vessel comes off. And so what's occurring now are endovascular or stent-like approaches to these therapies that use a combination of different types of stents, some of which are basically custom made on the spot by the physician, or physician modified grafts that allow you to leave the branch vessels open and not compromise the spine or the abdomen, and contain the aneurysm or the dissection. And again, primarily done through the leg and not done with open incisions, and with a lot less morbidity. It's pretty complicated stuff, but you know, in order for us to remain a premier heart and vascular center, we need to be working in this space. And what it's really great to see is the combination of the cardiac surgeons and the vascular surgeons working together to solve these problems. I hope that is broad enough to answer the question.
Thank you. Hey, we just had a statement come through too, just from a participant. My heartfelt thank you to Dr. Kugelmass for the exemplary care he provided and the many times he went the extra mile. His intervention saved my husband's life. So you've certainly impacted a lot of lives, but somebody wanted to make sure you heard that.
Well, thank you. Yeah, in my spare time, I do work as a doctor from time to time.
Hey, next question. I guess this is more philosophical. Can you share one of your most meaningful experiences from your time in your work at Baystate Health?
I'm going to have to ponder that, but I'll come up with a couple different ones. One would be watching the organization and watching the team somehow solve what seemed to be an insurmountable problem around COVID. You know, that's pretty deeply in my mind, particularly because it's a little closer than some of the other stuff. But you know, for those of you who didn't know, you know, we were hit pretty hard, and the tower, the heart and vascular tower, basically became the COVID unit. The intensive care unit was moved around. It went down to the second floor. Ultimately, it went to the Chestnut Ambulatory Surgery Center, and we were running an intensive care unit where they do endoscopy. The operating rooms were closed at one point and moved to daily. And we were by no means the only people who were moved around. The heart failure service was moved over to the old Springfield building. Other groups were moved elsewhere. Nurses on MM5 were basically turned into COVID nurses. But what was really striking was how well everybody, not just in heart and vascular, but the organization as a whole, rallied together, came up with creative solutions that constantly were changing for constantly changing challenges, and really got through it. And at least then in the case of heart and vascular, after quickly turning the system off, we were able to actually turn the system back on and get back to where we had been at baseline, really in a matter of months. So that's something that stands out. The continued expansion of the heart attack program, which was, to be honest, in its infancy when I got here compared to a lot of other places, including Henry Ford, to what it is now, was really something to watch. It's very mature at this point, you know, and now it's just a heart attack, right? It's not a big deal because we've done such a good job with heart attacks. People come in, don't get me wrong, people still succumb to them, but you know, people come in on one day and they're out the next day, and it's really an amazing thing. Watching the entire H&V center get built and opened, and the collaboration that went on in those early heart and vascular operating rooms between cardiac and vascular, and then cardiology and the TAVRs, that was really something that was really pretty special, because that's really what I was brought here to try to help catalyze. And then lastly, I think it would be the building of a program as opposed to a center. The concept of a cohesive sort of living organism that changes and adapts to the clinical needs and other needs of the community, it's not really fixed by a location. It spans the three, and to be honest, the fourth county being Berkshire, the four counties of Western Massachusetts, that changes its offerings and what it looks like and how it does things to meet the needs of the population. And if anything, that probably encompasses everything else that I just described. And that's probably the thing that I look back upon the most. And then I'm just going to share one vignette, which was, and hopefully this isn't violating any rules, but I got the pleasure of meeting a gentleman who probably did the first heart catheterization at Baystate. He was a really unique individual. He was about 100 years old when I met him. He had donated some money in memory of he and his wife's friends. And it is a dedication to one of the nurses who worked in the cardiac unit, to the extent that there was a cardiac unit back in the 60s and 70s. Ironically, two things have occurred. One, he passed away this past summer, and I was lucky enough to go to his memorial service up in rural Vermont, and that was a really touching experience, and get to meet his family and get to hear more stories about him. At the same time, I was caring for one of my 100-plus-year-old patients who was trying to make a very difficult decision around whether he wanted a very advanced procedure or not. And in the end, he sort of changed his mind and decided he didn't. And we had a family meeting in August or September about that on a Saturday. And I discussed with him that was just fine. As long as he was at peace with it, his family was at peace with it. That's what we're here to help him with that. And how I mentioned how I knew somebody else who was 100 years old who decided that at 100, maybe the most heroic things weren't necessary. And ironically, he identified the physician individual by name, because they too were best friends. Now, even more ironically, if I can find the stuff, these papers, which I found as I'm getting through and cleaning stuff out, are in fact the original cath reports, not from the 70s, but from the 1960s, that were in fact performed by this particular physician and donor. So it's a big circle. And so that's the philanthropy, clinician, patient side of all this. And it's maybe not as big as building a building or building a program, but it was pretty personal and pretty impressive. So hopefully that helps answer some of those questions.
That's very nice. Thank you for sharing that. For the group two, Dr. Kugelmass talked about our new operating and procedure rooms. Those are currently under construction. It's actually, we're the Baystate Medical Center, Baystate Health, we're building out just over 82,000 square feet to modernize our surgical rooms and procedures, 24 new operating rooms. The key is we're going to be going from our existing operating rooms, which were about 450 square feet, to 650 square feet. And what I've learned is modern surgery has a lot of technology, a lot of tools, needs a lot more space. And this is going to open up, we're planning to open us up in mid-March. So we're very excited. For Dr. Kugelmass, can you just talk about the impact, of a modern surgical space?
So, I think you did. There's a lot of technology that gets wheeled in and out of those rooms. Some of it's fixed, but a lot of it's mobile. These are huge teams. On the cardiac side, we were fortunate enough to have large operating rooms when we set out in 2012, again, because we needed the space because of all that technology. On the heart and vascular side, those rooms are going to be refurbished, actually, and brought up to speed 10 years later. In the cardiac cath and EP labs, those are the same size rooms. That encompasses a lot of equipment on the floor and then on the ceiling with the imaging systems, but a lot of other toys or gadgets, so to speak, that are used in various procedures. And to be quite honest, the cath labs back in the Daly building are on the small side for that, as are the EP labs. Everything just keeps evolving. So the size of those rooms is really critical to keep advancing the care that evolves from a technology and expertise perspective as these procedures become more complex and more technology intensive and also require very advanced imaging. So a lot going on, but having that space is mission critical. And I think, this, to my recollection, this is about a 50-year capital building project. And so the capacity to change those rooms 10 years from now or 20 years from now, and that technology changes and the techniques change, is also essential. And they've been built that way.
Thank you. Another question came in about research projects. Can you share a story to illustrate a research project the Heart and Vascular team is engaged with?
Right. So, I think the biggest ones are these big National Institute of Health grants, in the tune of $3 to $4 million over the span of 3 to 4 years. One focuses on techniques and interventions to help hospitalized patients with cardiovascular disease, stop smoking, because we know smoking is a huge contributor to cardiovascular disease. We also know it's an addiction, just like many other addictions that are coming forward. And for all the technology and therapies that we give to people, being able to get them to stop smoking is probably every bit as important, if not more important, not just from a cardiovascular perspective, but from other things, including cancer and other diseases. So this is a randomized trial of different interventions that Dr. Quinn Pack submitted for grant funding, and he got it to the tune of millions and millions of dollars. Another grant of his looks at interventions having to do with strength building in elderly patients relative to cardiac rehabilitation. So cardiac rehabilitation doesn't sound like a lot. You go over to the gym at 3,300, you start walking slowly on a treadmill, you get your blood pressure and heart rate monitored. They teach you some things about what not to eat, what not to do. They try to make you feel better over the fact that you've had a heart attack or bypass surgery. But so it may not be as sophisticated as some of the big computer operated and guided therapies that we're putting in those operating rooms. That said, its impact on reducing subsequent death or hospitalizations is every bit as big, if not bigger, than everything else we do in cardiovascular care. So his focus on coming up with innovative techniques for cardiac rehab, particularly in the elderly population, will have every bit as much impact as the newest stenting technique or the newest valve technique. And that's, again, a randomized trial that's being conducted here and at other centers. So those are the types of research projects that he's putting forward in collaboration with people at Cleveland Clinic and Yale and Henry Ford and other places. Then we have some more of the traditional sort of clinical trials of, does this device work better than this other device, or does it work better than what we would call placebo? But the thing I'm most proud of is that level of national funding, which is really a huge recognition of the quality of research that's going on, because less than 20% of grants are funded. We're in what we're called the top 5%. They're called the 5th percentile, but usually that's bad, but in this case, it's really good. Sure. One was in the 2nd percentile. So real statement to the quality of the research that's going on inside of heart and vascular.
Great, that's great. A couple more questions. This came in too. This is from a listener. I don't see any specialists, only my primary doctor. I have a history of heart disease in my family, both of the electrical and blocked vascular nature. Should I start seeing a cardiologist as a precaution?
I don't think you necessarily need to see a cardiologist as a precaution. I think that most primary care physicians should be able to address those issues. There are a large number of identifiable and either treatable or preventable risk factors for cardiovascular disease, both on the arrhythmia side and on the vascular occlusion side. And that's probably where I would start. We do have people who are interested in preventative cardiology. Dr. Pack is one of them. And that might be a one-time consultation, make sure everything's going in the right direction or get their input as to what's going on. But long-term, you probably don't need to see a cardiologist if you don't have the actual disease. At least that's my perspective on it.
And Dr. Kugelmass, I mean, from the minute you and I met 5 years ago, you've been a partner with the foundation. You're always a huge supporter. I guess just to wrap it up, how do the charitable gifts from donors impact the heart and vascular program?
Well, I mean, the one I've cited the most is I'm not sure that Dr. Pack would have gotten to the point where he got to had we not had the funds available to help subsidize the parts of his salary that weren't being supported during his training time. That would be one example. The training of nurses in new techniques and therapies like what's called ECMO or extracorporeal membrane oxygenation is another example. The training of surgeons in new techniques is yet another example. So I think it's mostly on the research and education side. We have used philanthropic dollars to purchase equipment. There have been some events in the past that were used to that purpose, but I think it's mostly programmatic. The other thing that I'll let you guys address is many institutions this size really have endowments that then are permanent support for programmatic needs or educational needs or research activities, usually at the discretion of the department chair, or in this case, the discretion of the service line leader.
Thank you. Hey, I'm going to wrap this up with a huge thank you to Dr. Kugelmass. Before I do that, I want to thank everybody for joining us, all of our supporters and friends who joined in to listen today and to participate. We really appreciate your continued commitment to Baystate and the Heart and Vascular program. Dr. Kugelmass mentioned the endowed funds. Those are permanent funds. If anybody would like to learn more, we're always happy to talk about how to be a permanent fund and or gifts to support our new surgery, ORs, and our interventional areas, and anything in heart and vascular at Baystate Health. We hope you found this information in conversation informative. And I was jotting down stuff about Dr. Kugelmass as he was talking, and a couple words came to mind. Impact. It's kind of an overused word sometimes. Dr. Kugelmass, I can't imagine the amount of people that you've impacted during your time at Baystate Health. So on behalf of everybody that you've impacted, thank you. Your legacy is going to live for a long time at Baystate Health. You're synonymous with heart and vascular. You're synonymous with a first-class person and doctor. So thank you. And speaking for everybody on this screen, or not on the screen, but listening, and everybody, from patients to donors to colleagues, thank you and thank you and thank you for all you've done. You've really made a difference in all of our lives. And appreciate everybody joining us today. It's very bittersweet. I wish that Dr. Kugelmass could keep on doing these, but we want to wish him and his family the very, very best in the future. And Dr. Kugelmass, I'll let you have the last word.
Thanks, Scott. So thanks for those very kind words. Yeah, my legacy will be that whatever goes wrong around here the day I walk out of here will be my fault. That will be one of the legacies, and I understand that, as does everybody on the call. But no, those are really, really kind words, all my sarcasm and joking aside. I want to thank everybody who took the time to get on the call, and I want to thank everybody who's supported the endeavors, not just of H&V, but the foundation as a whole. Without getting into too much detail and not belaboring things, working with the foundation and working with donors is in many ways one of the more rewarding aspects of my position, and one that I've really enjoyed a great deal. So thanks to everyone. Thanks to Scott. Thanks to Teresa. Thanks to Kate. And most of all, thanks to all of you. And thanks for taking the time on a lovely sunny autumn day to spend with us. So thank you. And you guys will be in my thoughts. And Scott always knows how to get a hold of me if he needs to. So thanks, everyone.